patients are advised not to change their lifestyle or medications without consulting their physician. Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto, the host of the Medical Society's podcast, Delaware Healthcare Reality. Today our subject is food is medicine. And I have two very good guests who can talk about this a lot because they're very interested in what this concept brings. The definition or concept of food is medicine is to prevent, manage, or treat disease, integrating the concept that into the healthcare systems. It emphasizes the power of nutrition to improve health outcomes, especially for patients with diet-related conditions, providing healthy food options tailored to specific medical needs. To my audience, I've done a lot of podcasts, and if you follow us, you know they've been interesting. This one will be the best because this one is going to be about how you can make your life better, extend your life, control your chronic conditions, and feel a lot better and understand what wellness is all about. There's an old adage, you are what you eat. You eat junk, you're going to be junk. Medical schools in my day did not really teach anything about nutrition. Yes, we learned that certain vitamin deficiencies can lead to diseases, such as a B12 deficiency can lead to megaloblastic anemia, or what was formerly called pernicious anemia. Vitamin C deficiency can lead to something called scurvy. Iron deficiency, obviously, iron deficiency leads to an anemia. And then you have vitamin D that can lead to rickets if you do not take vitamin D. And that's why we were fortifying milk with vitamin D in those days and still do. So today, medical schools are starting to realize the importance of nutrition in the well-being and health of our nation. And as you know, our nation is not the healthiest, falling in the line of 38 developed countries for outcomes. Yet we have the best equipment, the best physicians, the best medical schools. But if you look at the reasoning, it's because American people are not necessarily the best selectors of the way to live. We eat too much, we drink too much, we smoke too much, and some of us take drugs. These are things that have to be corrected if we ever want to improve the outcomes in the United States. And one way we can improve the outcomes is to listen to our two guests today who are going to tell us just how to do that. Our guests are Michelle Axe and Dr. Katelyn Fritzges. I will give you their bios now. Michelle Axe is a public health leader and an advocate focused on advancing the integration of food in medicine into healthcare systems to prevent, manage, and treat chronic disease. With over a decade of experience at the intersection of clinical care and community nutrition, she leads efforts to embed food as medicine interventions, such as medically tailored groceries and produce prescriptions, into standard healthcare practice. Her work emphasizes building strong referral pathways, fostering clinical community partnerships, and prioritizing local agriculture and culturally relevant care. Based in Delaware, Michelle is committed to using data to drive equitable access and improve outcomes, particularly for underserved populations. She is also actively engaged in identifying sustainable funding models to ensure the long-term viability of food as medicine programs within healthcare. Through her DPH program, because she is obtaining a doctorate in public health at George Washington University, Michelle aims to scale systems-level strategies that leverage the transformation power of food to improve health and advance equity nationwide. Our second guest, Katelyn Fritzges. Dr. Fritzges is an internist and pediatrician who graduated from Boston University School of Medicine and completed her residency with the Christiana Care Combined Internal Medicine and Pediatrics Program in 2018. She is currently working as a med-peds primary care physician with Christiana Care in Greenville. She holds a certificate in culinary medicine obtained through the American College of Culinary Medicine and supports the Christiana Care Food is Medicine program. As both a certified culinary medicine specialist and a foodie, she believes strongly that health food can and should taste delicious, and that healthcare providers should be trained to feel more comfortable providing evidence-based dietary guidance to our patients. So, panel, welcome.
Thank you.
Okay, let's get started. I gave the definition, I'll address this to you, Michelle. I gave the definition of food as medicine. Do you agree with it?
Yeah, I agree with it. I think it's important to highlight two parts of what we call food as medicine. And the first part, yes, is the provision of healthy foods to help prevent, manage, and treat a chronic condition. You know, some of those approaches that we're seeing are the medically tailored meals, medically tailored groceries, and produce prescription interventions. And based on the acuity of a person's illness or where they are in their health journey, you might prescribe a different type of intervention. And the other piece really is the intersection and connection with the healthcare sector. So these are patients that are, going into their primary care physician, and they're identifying based off of a certain eligibility criteria that this program would help them as a part of their care plan. So it's really normalizing it into just your traditional, core component of health for patients. And the other piece that I think is really important to note is that it's not food access. It's not nutrition security. Although they're similar, it's really important to differentiate between the two, and I'm happy to talk about that later, just because it has a lot to do when we're looking at model reimbursements and whatnot to not conflate them.
I do have questions for that about you later, but let me address this to Katelyn. Do we tailor the needs nutritionally to specific health issues such as diabetes, heart disease, hypertension, and obesity?
Yeah, I think ideally we want to kind of keep chronic diseases in mind as we're guiding people, but I'll tell you right now, the nutritional guidance for most of these things overlaps a lot. I think, as a rule of thumb, anybody with any of these kind of metabolic syndrome related diagnoses can really benefit from increasing fruits and vegetables. And so, one of the things I'll tell most of my patients is to aim for 5 fruits and vegetables a day, regardless of their diagnosis. So I think having a couple of those little rules of thumb that you can give to patients regardless can be really helpful, as opposed to getting, caught in the weeds of this is the specific guidance for this diagnosis versus this guidance is for another diagnosis, if that makes sense.
Thank you. I was going to bring an apple and some chicken soup today and say, did I take my medicine today?
Apple a day keeps the doctor
There
away.
you go. But all kidding aside, in the hospital setting, patients are usually given meals in accordance with their admission diagnosis. For example, diabetes, low carbs, sugar-reduced diets, etc. But what do we do when the patients get home? Do you provide diet plans, vouchers to buy healthy foods? Tell me a little bit about that, Michelle.
Yeah. So one thing that I appreciate with food as medicine, there is a right program for the right person at the right time. So if somebody's hospitalized, with CHF being their primary reason for their hospitalization, when they get discharged, unfortunately, those vouchers for produce prescription, they're not going to be enough for them, because they're not in the position to cut and prepare unless they have aid or support or from a caregiver to utilize and eat these healthy foods. And so what we suggest in that type of situation, your medically tailored meals is really where you need to connect your patients to. And so, it's this, you'll hear, it's a food as medicine program, and it's actually it's really nuanced based off of the acuity of the condition. And so those medically tailored meals, there's providers locally and nationally that you could enroll a patient into. I know, at least for Christiana Care, we currently don't have a reimbursed medically tailored meal program. We're in the process of talking to Highmark Health Options and finding that, but you're seeing in other states like Massachusetts, you might have a healthcare system that can directly refer someone to what we call an MTM program.
What's an MTM program?
Your medically tailored meal program.
Oh, medically tailored meal program.
Yeah.
Good. It's so hard to find a nutritionist,
Mm-hmm.
and it's so hard to find your insurance companies to pay for the patients to see a nutritionist. Mm-hmm. I would like to see us in some way, as a medical society, direct a change in that attitude, because we do know that in the long haul, if we prevent that patient from having a diabetic crisis or having diabetes itself, we've saved the system a lot of money. But you talk to insurance companies, and sometimes I might as well talk to the wall, okay? Right. It's hard to get them to comply with what we really would like to do. They don't look at the long run. They always look at that short moment, and that's it. Okay, so you're giving them a plan for healthy living. That's great in today's society. But I'm going to be quite frank. We're a fast-moving society. We're out there. I'm on the run. I'm not going to lie. I'll stop at Burger King, and if I need to take a Burger King, I'm going to have a Burger King for a quick move. Boom. Not good. No, it's not good. Mea culpa. But it's something that everybody sort of does. How do we change that attitude? Or is there a place to go that you can get something quickly that is a healthy way to live? How about you, Katelyn? Tell me a little about that.
Yeah, so I think a lot of times the advice that I'm giving my patients who are in these kind of dilemmas is I'm trying to find ways to meet them where they are. One example I always like to talk about when I'm giving lectures about culinary medicine is I had a patient who was telling me that she was going to McDonald's on a regular basis, just, as you're kind of suggesting. And when I kind of explored why, it was some combination of she just didn't have the time to really go home and cook. And it was also her back and her knee pain was so great that she didn't feel comfortable standing in her kitchen. And so what we agreed upon is that she would stock her freezer with frozen vegetables. And when she got home with her fast food, she would pop one of those vegetable bags in the microwave, steam the broccoli, and add it to her fast food.
That's a pretty good idea.
So, it's kind of about progress, not perfection, is what I always really like to emphasize. And so what I like to do is just really explore where my patients are, what are their barriers, and then kind of come up with unique advice for each individual to kind of at least get them one step closer to that healthy diet.
Very good. You're having a culinary degree. Are you a good cook?
I'm a decent cook, yes. So, and technically, so I have a certification in culinary medicine. I have not gone to culinary school as much as I would love to. But if it's all right, I'll tell you a little bit about culinary medicine.
Go.
So the concept of culinary medicine really arose because a lot of people had similar experiences to you, Nick, where they went to med school, they learned about vitamin deficiencies, but really don't feel comfortable talking to patients about their diets, when in fact we really need to know about diet in order to be treating these people. And the patients think we know these things about diet, right? The patients have an expectation that we can guide them.
Doc? What should I eat?
Exactly. And when you're like, vegetables, it's hard to take that into, an actual sustainable change when they don't know what that means. And if they walk away with the idea that, okay, I need to eat more of those sad salads, the one, the iceberg lettuce, one tomato and a cucumber that comes with your standard catering meal,
right.
Nobody wants that, right? So you need to kind of help guide patients towards healthier options. And so the idea of culinary medicine is basically to fill that gap. It takes evidence-based medicine and the art of food and cooking, marries the two together and really guides physicians, healthcare professionals, whoever wants to seek this certification in guiding their patients. And so it kind of involved some online learning just about different chronic diseases that are impacted by diet, but then also it involved hands-on cooking components where we learned, what's the right way to chop an onion? If you have a food that's too bitter, what do you add to change that? And it really guided us in how to guide patients. And so in my own practice, I try to, make sure I'm inquiring with most patients, at least at their annual visits, about their diet, and then trying to come up with some tailored recommendations specifically for them.
Very good, very good.
And she is a good cook.
Okay, that's nice to know.
I think
just no tofu, please.
Just means you haven't had it the right way, Nick. You haven't.
I got my entire team to try at least 2 different types of tofu.
Yeah, if you oven roast it the right way, it gets a crunchy outside texture. You can make it almost like a crouton. You won't even know.
I can make you a dessert with tofu, with some silken and a mousse. You wouldn't.
What'd you say?
Silken tofu, and you put it with some chocolate mousse. You wouldn't be able to tell the difference.
Chocolate mousse good for you?
dark
you make it
chocolate.
the right
Dark
way.
chocolate, gotta be dark,
with
huh?
the tofu, so you get the extra protein, dairy free. This one's dairy free, but
Okay.
challenge accepted.
So a big part of culinary medicine is actually the concept of how do we help patients to understand how to make healthy food taste good, right? Like, because that tofu that you just said is very common, but it's probably a matter of no one's ever shown you the right way to prepare it that you might actually enjoy.
Really?
Yeah.
And the reason why we go together so well is, so my background was hospitality business management. I thought I wanted to be a chef. Undergrad at UD, was the Airmark Fellow. Went down to North Carolina. I followed a chef, but your chef life is not as glamorous as the Food Network makes it look. And so quickly I realized my passion for food was also a passion for weekends and holidays and family. So I shifted my career, and thanks to Katelyn, I'm right now getting certified in a culinary medicine. It's the professional. So it's the person with a food background or food service can learn how to create different recipes. So together we can make recipes and then help our patients too.
Cool. You know, this goes back a long, long way. Hippocrates, the father of medicine, 400 BC, said, let food be thy medicine and let medicine be thy food. So this is no new concept.
No.
It actually is been around quite a long time. And I think Socrates said, eat to live and not live to eat. So I see a lot of people live to eat, and they love food, but they always pick the wrong stuff, and they blow up like balloons. And obesity being a major problem in this country, some 45% of the population being obese, leads to many disease entities, and again, another reason for our poor outcomes in the developed world. So I guess the right diet plays a very, very important role in your health. And I have seen people who have lost weight, either through a medication use or dieting, and starting to realize of the right foods to eat, and they feel better. Yeah. Their arthritis doesn't hurt as bad. Mm-hmm. They're not getting up 15 times to urinate in the night. They're starting to feel alive again, and they think it's a miracle. I said, no, it's just the right foods.
You're taking care of yourself.
And they understand that now. Why is it taking so long to finally come to this conclusion? I know that med schools don't teach us, and so we can't get out there and preach it, but they're starting to now, and they're starting to realize the importance of all of this.
Correct.
Why has it taken so long? Can you give me a good reason for that, besides fast society?
I think the challenging thing is that ultra-processed foods taste really good.
You got that right.
They are engineered to be delicious, they're engineered to be addictive, and they're shelf stable, they're easy to get, and they're cheap to make. And so, you've kind of set this up that it's the most accessible thing. It's going to taste good. People are going to reach for it. There's the advertising aspect, right? You've got all the sugary cereals that are advertising on kids' TV. So what are they going to reach for? And when you build those habits, it's hard to break them, especially if you don't know any better, right? A lot of us, I grew up in the late 80s, early 90s when, TV dinners and Kool-Aid and all of the canned prepackaged food were a thing. I didn't learn how to cook from my parents. I had to teach myself. And so how many other people out there just genuinely don't know how to cook healthy food and therefore don't know how to make that food taste good in the way that these quick options do?
Interesting.
And also, I think, too, that it's relatively recent where we've really pushed our focus to value-based care, and so traditionally it was fee-for-service, and so was there money in these preventative efforts, if we're looking from that perspective? So that's another thought I have too.
So how can you get support for such a program so that we can feed society properly? Does the federal government have to enter the picture? Do the state governments have to also comply? I.e., I'm not going to get political. I'm going to raise something later in this conversation about certain things to make America healthy again. That's whatever that goes for. But I just want to know, we usually use, food is actually there to sustain us, but many people use it for stimulation, distraction, for rewards or treats. And the purpose of food is simply to sustain and nourish us in a proper way. Do you agree?
Yes, but what I like to emphasize with patients, because it's a fine line between eating a healthy diet and creating an unhealthy relationship with food. right? Like, I don't like the idea of making people feel guilty for the way that they're eating. And let's face it, sometimes you just really need a cookie, and that served a purpose in your life. But it's everything in moderation, right? We can't have 6 cookies every time we feel sad. We need to kind of think about, how are we going to regulate that? How are we going to find better ways to regulate your emotions?
I like ice cream when I'm really sad.
And you know what? Like, I enjoy an ice cream cone too. But at the end of the day, I don't eat it every day, right? I still incorporate my vegetables. And so it's an everything in moderation. But I do also want to just be really conscious of the fact that, you know, with the wrong phrasing of these interventions, we can really put patients down a wrong path and lead to over-restriction and things like that.
And then they regret it and don't follow it.
Yeah, I also think if you're too restrictive in your recommendations, you run into a situation where it's just not sustainable. And you get into this mindset of, oh, well, I already messed up, quote unquote, on my diet and ate this piece of pizza, so forget it, I'm already off the train. I'm just going to go eat the french fries and the ice cream, and I'm going to have a beer, and I'm going to add all of this other stuff to it because I already screwed up, right? Whereas if it's kind of an everything in moderation standpoint, it's a, you know what, I had an ice cream today, tomorrow I'm going to have some yogurt with fruit when I have a sweet craving instead, right? So it's about balance as opposed to like that super restrictive idea.
Got it. Well, I don't know, my taste buds are such that they're already programmed. So it better taste good, or I don't want to eat it. So instead of me going to sodas, chips, and, you know, carbohydrate-rich foods, being Italian, I'm, you know, carbohydrate heavy, it has to taste good. Now, you said you can make tofu taste good. I got to take you up, Michelle, on your challenge. But how do we... Some people, when they're under stress, and we have a stressful society, these foods that are out there that are not necessarily the best give you comfort. We know that chocolate, ice cream, and things like that do give you comfort. It does. It does something in the brain that makes you go, ah, you know? It's like that person who's a smoker, quits for 6 months, and then some stressful situation comes along. He takes a cigarette, and he's back on the cigarette kick. How do we get them to feel? How do we get them to eat properly and then realize that they feel good? What do we do? What do we do to make that happen? Is there a special food combination that makes you feel good, that it's actually good for you?
I think the first step is that we need to be better about teaching people how to make healthy food taste good. And so that's where, you know, one of the things that Michelle and I will be piloting this fall is actually shared medical visits in a teaching kitchen. Well, we'll bring 12 patients together who have, you know, a diagnosis of something like diabetes, high blood pressure, heart failure. We'll bring them together and actually teach them how to cook as we're talking about these nutritional principles. And so they'll have the opportunity to build skills. They'll have the opportunity to ask questions. They'll have the opportunity to try foods that they wouldn't have purchased on their own because, let's face it, groceries are expensive. Nobody's going to buy a food that they're not sure if they're going to like and if they don't know how to cook it.
Exactly.
So by bringing these people together, we give them the opportunity to learn how to make healthy food taste good and then hopefully make sustainable changes for themselves and ideally for their families because most of these people aren't cooking just for one.
Go ahead.
And then they're enrolled in our medically tailored grocery program. So as Katelyn is showing them what they need and how they can make things, our community health workers are partnered with them and can help them select a menu and bring home a bunch of food for the next 6 months for them and their families. And so it's this combination approach with the culinary education plus your food provisions, community health worker support, and education from your doctor.
Did you ever think about you guys starting a TV show on this?
Maybe this is our first.
Seriously.
Hi.
Seriously, a TV show. I would love to watch it, and then you could show me how you can make tofu taste good.
Once we have our kitchen set up, we'll make sure there's a camera.
We can make that happen.
You can do that?
We're going for grants. We'll see what we can get.
Oh,
we got a mini one. We got a mini pilot.
Yeah. Okay, great. Okay, just give us a couple examples for my audience, and I'm going to list the disease entity, and I want you to give me just a brief overview of what you should tell this person to eat to make them feel better and control their condition. Obesity. Give me examples.
So the biggest thing, and you're going to hear me sound like a broken record because I will say the same thing almost every time. So with obesity, what I'm going to encourage is increasing healthy foods. I don't always talk about restricting the unhealthy foods. And in fact, there's actually literature specifically in pediatric obesity literature where they took 2 groups of obese teenagers. They told one group to increase their consumption of healthy foods like fruits and vegetables. They had the other group really restrict the unhealthy foods. And the group that was eating more healthy foods were the ones who lost more weight. So I think, and there's something psychologically speaking about telling people to eat more of something that just doesn't feel as difficult, right? So often what I'm starting with is, hey, can we add a vegetable to dinner? Can we add a piece of fruit with breakfast? Can we snack on fruit instead of on a chocolate bar? You know, what changes can we make to just kind of like move that needle so you're getting those 5 servings of fruits and vegetables?
Okay, so you would give them, you want to eat more fruits, and you say, can you eat too many of them? Can you eat too much fruit and get to problems with gaining weight, or no?
In my opinion, no.
Okay.
The reason being, one, when you look at the calorie density versus the nutrient density, right? So when you're eating a candy bar, it's going to be calorie dense, but not nutrient dense. You're not getting much that your body actually needs out of that. Versus if you eat an apple, you are getting more nutrient density. So it's going to be a lower calorie option, but you're getting fiber, you're getting vitamins, you're getting minerals, you're getting things your body needs. That fiber is also going to fill you up, so you don't have as much room for the things that we don't need, like the candy bars and things like that.
Maybe on the labels of foods, we should have a density plot, or a density as opposed to how many calories you're going to take in with this particular meal or whatever. That would be interesting. I think that'd be a way to do it. All right, diabetes. We all know carb restriction. But that's hard to do. It's really hard to do. Is there any tricks we can get around that? Tofu, I know. But is there anything that could go?
So what I emphasize for my diabetic patients is the quality of their carbohydrates. So I think a lot about whole grains specifically. So your whole grains are kind of what I think of as more of like the brown carbohydrates. So it's going to be your whole wheat bread as opposed to your white bread, brown rice as opposed to white rice, farro, quinoa, oats, things like that. And the reason that those are more important is because you get fiber along with that carbohydrate. And that actually mitigates how your body absorbs that sugar. So your blood sugar spike is not as high, and you actually don't absorb as much to begin with.
Very good.
And so it's gonna modulate. And the same thing with fruit, actually. One of my pet peeves is when people in healthcare tell their diabetic patients not to eat fruit.
Really?
Yes, because ultimately, because there's fiber in fruit, it acts just like that complex carbohydrate, just like that whole grain.
So it blocks
it mitigates the blood sugar spike.
That,
And so I think it's really important that we don't limit people on fruit. But that's, one of my soapboxes. We may need to, obviously adjust insulin regimens and things like that if people are eating a lot of fruit, but I think that trade-off is worth it for the the vitamins, minerals, and fiber that you're getting from those.
Good. I hope you all hear that out there. Heart disease.
So with heart disease, again, same thing. One of my favorite studies actually looked at number of vegetables consumed, fruits and vegetables collectively consumed, and compared it to overall cardiovascular mortality, and they actually found a 4% risk reduction in cardiovascular mortality for each additional serving of fruits and vegetables, up to a total of 5 per day.
That much?
And that was additive. So if people were eating 2 servings of fruits and vegetables and they increased to 4, they reduced their risk of cardiovascular mortality by 8%.
Wow.
Which is, I think that's really staggering. I think we start
staggering.
We start statins for less risk reduction than that.
Exactly. I mean, we're using statins to lessen heart disease, and yet just simply eating 8% reduction you get?
2 servings of fruits and vegetables. Yeah, each serving is 4. So if you have somebody eating none and they add 5, that's 20% risk reduction.
Wow.
Put the article at the end. We'll make sure.
I was going to say, we'll find that one.
Okay,
right.
I believe you. Yeah. All right. Now, there's one disease entity that always baffles me, and we're seeing it rise more than I've seen at the beginning of my profession, and it's autoimmune disorders. I don't know if any of you believe in leaky gut. Is there such a thing?
I have severe ulcerative colitis, and so not leaky gut. So you just said autoimmune, so I'll jump in quick, and then we can get back to your question. Maybe you have an answer. But I had failed on every single biologic you can imagine. I went to my doctor all the time at Christiana, then I had to go up to Penn. We're talking Humira, Remicade, or TNF blockers, and then switch to Entyvio, and nothing was working. I would go to Christiana Care ED due to dehydration, loss of blood, and I didn't know what else to do except change my diet. So I'm incredibly strict with reducing, for me, gluten, preservatives, sticking to whole foods, a plant-forward diet, and I have been in remission for 5 years.
Really?
I don't even take medicine anymore.
So it shut your gut?
I just see my doctor, and I'm not saying not to take your medicine. I'm not saying that, but I'm saying for me personally, and I asked my gastroenterologist, I said, should I be on medicine because I'm starting school? And I'm like, am I going to get stressed? It's a trigger. And they said, you're doing great. keep going and get your colonoscopy, but as long as you're in remission, we're not just going to go back and put you on medicine.
I have a few ulcerative colitis patients similar to you.
Yeah.
And they are not doing well on biologics either. Will you in some way send me or, what you're
Absolutely.
doing to help the problem? Because I don't know, I'm a leaky gut kind of guy. I don't know if there's if there's true belief out there that there's such a thing as leaky gut. We have a gastroenterologist here listening in. That's Dr. Dave, and he may be saying, I don't know either, but but I don't know. And maybe just simply changing your diet and plugging the leak is what's made you better. Who knows?
And
okay.
I am going to get on my soapbox real quick before you shift.
Shoot.
So the other thing, yes, I'm acutely aware of the impact that food has on health, but I'm also acutely aware that I'm privileged to be able to afford the healthy foods.
I was just going to get that. Are healthy foods expensive? Is it expensive to have healthy foods? I'm going to come back after our break and ask you that. Think about it.
Okay.
We're going to take a short break, and we'll be right back.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Okay, we're back from our break talking about food is medicine with Michelle Axe and Dr. Katelyn Fritzges. I ended the last segment before the break as saying, how expensive is it to eat healthy? Can one of you comment on that?
Yeah. So I think it can feel expensive to eat healthy. For example, if you're going and purchasing all organic foods, which you do not need to do, there's no health difference between organic and not organic.
Good to know.
And even, fresh versus frozen vegetables. Frozen still captures that same amount of nutrition as the fresh vegetables. So I think if you are being smart about it, you can eat healthy in an affordable way. So it's really about, frozen is okay. You don't need organic. Plant-based proteins are cheaper than meat. So a can of beans is always going to be cheaper than, a couple pounds of chicken breast, things like that. So there are ways to eat healthy without breaking the bank.
Got it. Now, Katelyn, your culinary medicine background, you would like to see something happen at your hospital, Christiana Care, to allow patients to be seen by you in some way being a nutritional counselor, but seen under the CPT code of seeing a primary care physician, therefore bypassing the nutritionists, which are so hard to get to and so hard to get paid for by the insurance company. You're working on that?
Yeah, and I do want to emphasize, I see culinary medicine as an adjunct to what our dietitian colleagues can offer. I do think they play a really important role in this. Mm-hmm. But I think culinary medicine allows us to take it a step further and also allows us to touch those patients who are not able to access dietitians. And so what I'm exploring is the opportunity to actually offer culinary medicine consults, which since, as a primary care physician, I could see any patient with any kind of diet-related chronic disease, specifically focus in on the nutritional recommendations for them and kind of tailor that to their own personal needs. And that would be billable as a primary care visit. So there actually is opportunity to do this work and generate revenue for hospital organizations.
Interesting.
And one thing to piggyback off of Dr. Fritzges is that, you're right, registered dietitians aren't covered as well as they should be. On our Medicaid and Medicare coverages. And so what we're seeing on a policy level is Lisa Blunt-Rochester did co-sponsor a medical nutrition therapy bill to expand the coverage. So a pre-diabetic patient can actually, start talking to a registered dietitian before they have diabetes. And so, will that get passed? We're not sure, but...
Why wouldn't it be?
Politicians say, So why wouldn't it be? I think what's hard with nutrition interventions, different than perhaps reimbursement for your hypertension medication, is you see results quickly. And so when we're talking about medical nutrition therapy, yes, it's expensive up front, and it's going to take a long time, or at least longer than giving someone medication, to start seeing the impact on an individual's health and ultimately, the return on investment as it relates to hospital utilization. And so perhaps it's not as upfront. Like, you're not going to get that quick, we're in the microwave society, your quick results, because by nature, it should take time. And so perhaps that's why I'm sure there are many of people who could chime in and give their own theories.
When you look at the long haul, the cost to take care of these conditions is outlandishly large.
$1.1 trillion.
You go. You got the number. Good for you, Michelle. But I'll tell you, it's large. So why won't the government look at it that way and say, we may save in the long haul a lot of money if we put a little bit, not a whole lot, but a little bit in this? Why not?
I think we are starting to.
Okay,
so throughout the country, Medicaid has what they're called 1115 demonstration waivers. So essentially they're pilots to, if approved, states can include nutrition services. And we're seeing things like medically tailored meals, medically tailored groceries, prescriptions to be reimbursed. And the purpose of this demonstration, or we'll call it like a pilot waiver, is to look at the data and see if they're making an impact. And if so, maybe our payers will look into investing this. And I'm proud to say Delaware is one of them. There's, like I said, 16 states that have either approved or pending, and Delaware's has been approved. It is for a specific patient population. For us, it's postpartum women. However, other states have a broader criteria for usage, and there's opportunities for Delaware to put an amendment and potentially broaden that scope to be for primary care patients. So I think we're headed in the right direction.
And Blunt Rochester is pushing this along.
Lisa Blunt Rochester, Senator Coons, Delaware, we're really lucky. Even our governor, he started the Delaware Food is Medicine Committee. We've been having conversations with experts from North Carolina, Massachusetts, California, some states really leading in this space, New York, and I'm hopeful. I'm very hopeful. This is the most notoriety that we've seen in decades. And for me, I've been in it for my first intervention back in 2018, so it hasn't been that long. However, some of these institutions and organizations have been doing this for years, or for decades.
Tell me a little bit about your food pharmacy.
Our food pharmacy.
Pharmacy with an F.
Pharmacy with an F, and that's on purpose because we do get local food procurement because our local food system in Delaware is just as important as the health of our community. And so our Delaware Food Pharmacy is for two patient populations. It's for our primary care patients who are diagnosed with either diabetes, hypertension, congestive heart failure, or for our at-risk pregnant mothers who are experiencing obesity. And what it is, it's a 6-month, medically tailored grocery program. So it's not the meals one, it's the one where they get to select from a DASH diet compliant menu for primary care. For women's health, it's Mediterranean diet, and this is more for recipes because, to Katelyn's point, it's pretty transferable. We just focus a little different on our tailored recipes. And they get food every single week. It's either delivered or picked up at their convenience because we understand that if you want an intervention to work, it has to be easy for our patients. And so it provides food for them in their household, not just family, because we have, family, people that live in their home aren't necessarily your family, so that's important. And then it's paired with the community health worker because what I like to say is that the majority of these patients have food insecurity, and food insecurity is the canary in the coal mine. It's telling us there's probably a few other social drivers of health, and so the community health worker can help to address any other social needs that they may have, because if I'm not able to keep the lights on in my home, I'm really not going to listen to Dr. Fritzges when she tells me that I should eat a certain way, because that is my survival mode right there, your basic needs. And so I think really incorporating that. And the other thing that's so great with the community health workers is that they're ServSafe certified. So they're able to safely go into the patient's homes and prepare meals with them and teach them the skills. And I'm excited, thanks to our pilot with Dr. Fritzges, the last phase an enhancement that we're doing with our program is we're going to upskill our CHWs to be certified in certain culinary medicine education. So no, they're not here to be Katelyn, but they're here to continue the messaging once they're done in the homes. So that 6 months is really what you need for a behavior change. So the 6-week series is great, but how do we continue to expand upon that knowledge and really empower the patient to adopt these behaviors post-program?
Now, you said if they have diabetes, hypertension, obesity, those kind of people qualified, but is there a financial tag? Do they have to be, do they have to have, they're in the poverty level or they're on Medicaid? In other words, it can't go to somebody who does all right but is still obese. You know what I mean?
So right now, it's our Medicaid patients, some Medicaid, Medicare, dual eligible. But I will say that the food is medicine movement overall shouldn't just be for
I agree.
Our patients that are food insecure or a certain low income, because we're trying to help the nation.
I agree.
And the education, the access to food and learning how to make healthy food taste good is what is needed for whether your payer is private or not, to see systemic change as a nation. Okay,
gotcha. All right, this was a very good interview, if I have to say so. You've done wonderful, both of you. My last question, and it's not meant to be the political question. Mm-hmm. There is that program Robert Kennedy's running called Make America Healthy Again. That's a good philosophy. Let's try to make it healthy. He's done some quite good work with removing some of these dangerous oil-based dyes from a lot of our food products. How do you feel about that particular program? Do you think it's going to be beneficial? I don't want to talk about vaccines because that's another bugaboo coming up in a later podcast. But tell me what you think about the Make America Healthy Again.
I will talk about it specifically from the knowledge base I have as it relates to people leading the Food as Medicine national movement, mm-hmm. is that we do have a seat at the table in that regard. So he's listening to national leaders and physicians who have been really pushing food as medicine and who have even helped Delaware as we're developing our Food as Medicine committee, so Tufts Food as Medicine, for example. And I'll take that as a win. I will say the movement as a whole is trying to be strategic into what pocket or what area of patients could we get almost like are more likely to get our win. And so maybe we focus on this administration on our Medicare patients and perhaps less on Medicaid, not saying you won't have foundations that are supporting Medicaid support in Food as Medicine, but in my mind, it's like, okay, maybe it is Medicare. But it's sometimes it's like reading tea leaves, as I like to say. I don't know, but I'm happy that we're at the table, and
at least the subject is being broached.
The subject is being broached. Yes.
So I think we need to make America healthy again. Okay.
And I don't know if Katelyn has anything to say.
Anything to say?
She has the other side.
I think so. I appreciate the Make America Healthy Again movement for the opportunity it brings to have this conversation. I do think, people on either side of the table are interested in this idea right now. I do have some concerns about where they're focusing their efforts. Sure, is it great to remove some of those food dyes? Yes, but a sugary cereal without food dye is still a sugary cereal. So I think, getting to the actual brunt of things, I have yet to see.
So in other words, they're dealing with the dyes in the cereal, but not the sugar in the cereal. So you would like to see an overall approach to healthy foods.
Exactly.
I think that's going to happen. I hope that's going to happen.
I hope so too.
So let's be positive thinking on this issue because, again, too many kids are sick, too many kids are obese, we got to get those kids to learn what good eating is and get them out of that poor eating habit.
Exactly.
Well, this has been an interesting and very enlightening interview. I'm really happy that the two of you could make it and give our audience a good view of what you're doing, and hopefully you get a lot of support from what they hear and a lot of implementation in their lives. Now, if they want to learn more about this Food is Medicine program, how do they do that? I guess I could ask you, Michelle, and then if you have any additions, Katelyn will add. Go ahead, Michelle.
Yeah, I think the American Heart Association, their Healthcare by Food initiative is a trusted source that I would go to. They have coined a national definition to which our Delaware definition is taking from and making it Delaware. And I would say that it also breaks down the different types of approaches, so medically tailored meals, medically tailored groceries, produce prescription, and potential patient populations that could be good. You have the Rockefeller Foundation for their Food as Medicine work, Tufts Food as Medicine Institute, and then, of course, Christiana Care. We have our Food as Medicine webpage as well, where both Katelyn and my contact information are on there. And we pulled a lot of the information and the content on our website from those trusted sources, too.
Great. Thank you very much, both of you, for a very interesting and enlightening podcast. You want to add to that, Katelyn? Go ahead.
So I did
just
want to add. So if anyone's interested in learning more about culinary medicine certification, so culinarymedicine.org is the American College of Culinary Medicine website. They've also got some great resources, recipes, things like that. Another great opportunity to get some CME and learn more about culinary medicine is the Healthy Kitchens, Healthy Lives conference that's held every year in Napa. At the
place to go.
Yes, it's
actually
how
good?
she
Is
started.
wine good for you? Go ahead. I'm
Red
sorry.
wine is on the Mediterranean diet.
There you go.
But the Healthy Kitchens, Healthy Lives conference is held at the Culinary Institute of America in downtown Napa in conjunction with the Harvard School of Public Health. So it's a really awesome opportunity that brings people from the food world and the health world together to really learn more about culinary medicine.
Very
it's the
good.
thing that got me inspired, and it's an incredible conference.
To
I
get a
really recommend
culinary
it.
degree, how much time is that? Is that like a PhD in biochemistry?
No, so the culinary medicine certification is actually just, there's 30 modules that you do online, and then there are a handful of modules that you do in person in the kitchen, and then you take like a 100-question board exam, just like you would if you were taking the IM or PH boards.
You could do that at your pace too, couldn't you?
Exactly. It's all self-guided with the exception of the hands-on portions, which you can do in person or you can do virtually from home in our post-COVID era. So it's actually very accessible. I basically did a module every weekend for, under a year, I would say, took the test, and now I have that certification.
Good for you. Well, thank you very much, Katelyn. Thank you very much, Michelle. Very glad to have you here at this wonderful podcast. I've learned a lot, and I think our public will also learn a lot. Thank you.
Awesome.
Thank you.
This is
Appreciate the
Dr. Nick
opportunity.
Biasotto signing off. Have a good day and eat properly.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast. Patients are advised not to change their lifestyle or medications without consulting their physician.